talk about post-surgical pressure injury prevention. The word was switched from ulcer to injury to encompass any skin injury that can happen during a hospital stay. The objectives for today are to identify the post-surgical risk factors for developing pressure injuries, analyze the outcomes of current post-surgical management, and apply the current UMMCH post-surgical and skin assessment care policies to the case study presentation. What is a pressure injury? It's any localized injury to the skin or underlying tissue, usually over a bony prominence from unrelieved pressure. And the highest risk for pressure injury in adults is the sacrum. Anybody have any ideas for kids? Where the highest risk is? It's the back of the head, the occiput. So there's not as much fat tissue there, and that sticks out the most in children. It's documented about 20% of PICU patients get pressure injuries, and that's usually within the first 2 days of admission. I wasn't able to get the rates on floor patients, but for ICU patients, about 20%. What are the risks? So there are intrinsic and extrinsic risk factors. Intrinsic factors are what the patient already has, such as immobilization, being wheelchair bound from CP, increased pain, surgeries, incisions, drains, poor nutrition, and any other chronic medical conditions. And the extrinsic factors are what we do to the patient, such as bringing them up in bed, failing to reposition them, not providing good nutrition, or leaving them with moisture from briefs or sweating and things like that. So the case study. So this past December, a 9-year-old patient was with a past medical history, significant for intrauterine malrotation, intestinal malrotation, short gut syndrome, status post multiple small bowel lengthening procedures, a liver transplant, partial small bowel transplant, partial pancreas transplant, and previous G2 placement, was admitted to Unit 5 from the emergency department. Earlier that week, the home health, or that patient had a drain placed around the G-tube site to drain a fistula, and the home health nurse had noticed that the drain was putting out more drainage, so she decided to draw labs, and he was found to be hypokalemic with an increased BUN, white blood cell count, and CRP. She called in the labs to the GI physician here, and he encouraged her to bring him into the hospital, and he was admitted to Unit 5 from the ED. He got there late that night, and then the next day, upon rounding, the surgery team decided to make him MPO to perform an exploratory laparotomy, gastrocutaneous fistula takedown, and resitting of the G-tube site. His allergies include vancomycin and tegaderm that were documented in 2011. So the kind of overview of the timeline, around 1:30 that afternoon, an epidural was placed by anesthesia for post-procedure pain management, but there was no PCA, IV, oral, or G-tube medications prescribed, or no PRNs prescribed. He was successfully transferred to the PACU, denied pain, and was approved to transfer to the floor. Shortly after arrival to the floor, he complained of increased abdominal pain and refused to be repositioned, but he was transferred to the floor bed with the hover mat. The hover mat was allowed to be left underneath him because of his increased pain, so they decided the pain was the priority at this point, and once the pain was under control, they would remove the hover mat. The pediatric inpatient pain team was called for pain concerns, but they were unable to send a team member because they were stuck in the OR. So at this point, what would be your next step to get this patient's pain under control? So if the PICS team, right. So who would you contact since the PICS team is unable to?
Ped surgery, first of all, and if ped surgery won't do it, then you call GI.
Okay. So the peds GI team was actually consulted first by this nurse, and a one-time dose of IV hydromorphone was prescribed, and the nurse gave that, and the patient say that that helped his pain and he was more comfortable and able to rest. But is this pain plan sufficient? Later that evening, the PIPS team came to the bedside and the epidural was assessed. It was deemed non-therapeutic and was pulled out. At that point, it was noted that a tegaderm dressing was used and was removed. However, there were no skin issues at this time. He did complain of pain right when the PIPS team left. And again, there was no primary care team listed, and the RN was unaware of who to page at this time. She did end up paging surgery, as we kind of talked about. They stated they were no longer managing his pain, so she then paged GI, who again did write for scheduled hydromorphone with PRN doses. So, how can we improve interprofessional communication and pain management for this patient? How can you get the message across that you need improved pain control?
You need to pick a team to start your communication with and explain that, you know, we've got this situation here, so we have this kid who's post-operative. We don't have a good pain plan in place. It doesn't appear, you go through your whole SBAR background, doesn't appear
perfect.
good assessment. We have unmanaged pain recommendations. We need to communicate as a team to come up with a better plan for
Exactly. So using your SBAR and your AIDIT to get that closed loop communication. So you could say to the PIPS team or the surgery team, okay, if PIPS team isn't going to manage, do you feel comfortable contacting surgery, or do you want me to contact surgery? And then if surgery says no, then you say, okay, are you okay with me contacting the GI team and having them develop the plan of care for the rest of the evening? Because nobody had talked to anybody that did surgery, and the GI team didn't know the epidural was removed, and nobody kind of realized that there was no pain plan in place. Later that evening, the patient requested to be repositioned to his back. The hover mat was still underneath him, and there was still no skin concerns at this time. And the GI team was notified of a fever of 102.1. And what could be other causes of that fever, despite all of his issues? So he's in severe pain, still on the hover mat, not being repositioned.
It gets hot.
So the hover mat's a heat conducting material, which is why we try to remove that right away. He had decreased lung expansion and was actually put on oxygen because of that, which is most likely due to his pain and decreased repositioning. Tylenol was given, but the patient continued to complain of increased pain throughout the night. Hydromorphone was given 7 times, and Tylenol was given a total of 4 times, I believe.
4 times in 8 hours? Or 4 times in 2 shifts?
Probably 4 times in 2 shifts. Early that morning, the GI team was again notified of the ongoing pain. The resident came to the bedside to assess the patient and noticed some areas of redness on the shoulders, but the patient refused to be turned and repositioned all the way, so they made a plan that they would reassess with the entire day team in the morning. At right about shift change, the attending surgeon came to the bedside, and he noticed that the hover mat was still under the patient, and came to assess. The patient noticed significant redness and blistering. He personally cleaned his back, applied a dressing, and then prescribed a PCA that the RN then initiated. So, this is what was found that morning. So as you can see, this is the epidural site here. And this is where, so there's tegaderm on both sides. This side was noted to be cleaned by the grandma. This side had been laid on the hover mat. This was a full blister that's now indurated, along with the other blistering and drainage and redness. So the RN did a good job, the night nurse did a good job of coordinating a pain plan but what standards of care were lost for this patient?
They removed all that stuff and then from the
It's really surprising knowing who this is, that he would refuse to move.
oh no, he was like,
But I suppose it hurts so bad.
So yeah, so skin assessment and repositioning was obviously not performed. So just making sure to use all of your resources such as the NSTs, flyers, other nurses on the floor to really encourage the patient to move, getting the materials out once the pain is under control, making sure that hover mat's removed right away and that the patient is being repositioned every 2 hours at a minimum. So the UMMCH skincare policy is to do a head to toe, front to back, every crease, every fold, skin assessment twice a day, upon admission or upon transfer, and that can include from ICU to floor, floor to ICU, PACU to the floor. That can include any transfer. And then the Braden score needs to be performed at least once per day with interventions documented every shift. The only people that are allowed to stage a pressure injury is the wound care nurse, a physician, or any RN who's been specifically trained in staging. And all wounds must be documented in the electronic medical record.
Do you need Braden interventions? Sorry, do you need Braden interventions even if they have an acceptable score? If they're not like a
No.
high-risk score? Okay.
Nope. Other post-surgical management is obviously removing all of anything that's used to transfer the patient's sheets, hover mats, blow-up mattresses, any drains, devices, tubing that's stuck underneath the patient, making sure it's clean. Repositioning the head and body every 2 hours, suspending the heels, protecting any bony prominences, optimizing nutrition, and decreasing moisture. One thing to note is that if the friction shear score is less than 3 on the Braden, then the head of the bed needs to be below 30 degrees. So, deviations to standard of care, inadequate pain management, patient not appropriately being repositioned, use of the Tegridin product despite listed as an allergy for several years, the hover mat left underneath the patient, poor provider communication, and the failure to appropriately document the pressure ulcer injury in the chart. So again, here's the photo from the results of the patient. And things to remember are to make sure that there is a primary care team listed, and if not, continue to use that closed loop communication to figure out who will be taking care of that patient using your SBAR. Making sure that you have the appropriate pain medications prescribed and PRNs and use them as prescribed. Promote clear communication using your tools. Removing the hover mat immediately upon arrival, and these are the exceptions. So if there's severe intense pain, again, you can wait to get the pain under control, but making sure to remove that as soon as the patient scores their pain lower. Or if there's a near future transport. So sometimes the patient will go to MRI or CT later in the day within a couple hours, and that is fine to leave it underneath them for that. Immediately complete your skin assessment. When you roll the patient from side to side, get the sheets out, that's a perfect time to do a front to back, head to toe assessment. We talked about that. And repositioning every 2 hours. So again, just kind of a wrap up. There was obviously a lot of faulty things that happened in this case. Everyone kind of dropped the ball in different ways. But the main take home here is based on skin assessments. So just making sure that we remember the Braden, remember doing our BID assessments, and providing those interventions. Other teams will be contacted with the communication aspect. But skin is the largest organ in our body, and we just want to keep it safe to decrease infection. Any questions?
I have a question. Are we liable for what it costs to treat that pressure ulcer then? Like, what does the hospital have to do?
Yeah, so anything that if the patient didn't come in with it and they receive or obtain it at the hospital, then Medicare does not reimburse. So no insurance companies will reimburse for this. The hospital will eat those costs. And treatment can, you know, be creams, antibiotics, and then obviously if it gets super deep, can be wound vacs, depending on the degree of, and the hospital is responsible for all of that.
What was his treatment after that pressure ulcer was staged?
He just required ongoing cleaning and dressings with like the Mepilex, obviously not Tegaderm, and then just keeping it open to air throughout the day to heal it. But
I didn't put Tegaderm on him, right? So was
Yep.
was that a cause of any of this, or was that just? Because I remember the Benadryl was ordered. Is that because of the Tegaderm?
mm-hmm.
Yeah.
So there wasn't no reaction.
Yeah. Yeah, he's had known reactions in the past, and family members state that usually it's with prolonged use, but with, although it wasn't on super long, it was on the heat conducting material that probably just kind of
Cooking on that.
cooked it right in there.
Yeah, he was on that
And we have other
Any other
other
questions?
materials that we can be using other than a Tegaderm that are still able to view
Yep,
through.
we have the IV3000, the Opsite, Mepilex. There's multiple different options for. Thanks for coming.
Thanks.
You can stop.
Alright.